All right. Welcome to Counseling Stars for students by students, where real conversations meet real preparation for the counseling field. We are super excited for today's Constellation feature. In today's episode, we're going to dive into a topic that touches every community, every system, and often every family, and that is addiction. So we are here with Dr. Rebekah Hodge. Dr. Hodge, would you like to give a brief intro to the listeners?
Hi, everyone. I just want to start by saying thank you for this opportunity. I think this is an awesome way that you all are connecting with your peers. So just wanted to give you all a shout out for that. But yes, I am Dr. Rebekah Hodge. I am currently in New Mexico. I gained my PhD in 2022, but I've been independently licensed here in the state of New Mexico since 2015. When I was in my master's program, I said the one area I'll never work in is addiction, and ended up there. Never say never. So I've worked in addiction for many years in different areas. So some inpatient, some outpatient, and currently I work in my agency. We work with the court system. So sometimes we work with people who have gotten a DWI. And so I promise you, it is the one area that you can't get away from. So never say never to that. And in between all of that, I have two little girls that take up the rest of my time. So I guess that's enough about me.
Amazing.
So, Dr. Hodge, we like to start our episodes by, you can see in the chat there, Amanda has dropped the feelings wheel. This is actually born from my experience as a grief support group facilitator with Calm Waters here in Oklahoma City.
Nice.
And I think it's a really cool exercise one, it's like offers us a moment to be introspective, which can be hard in our everyday busy lives, and also highlights for us maybe the things we're bringing into the room or bringing into the session or this opportunity, this engaging conversation we're about to have. So I'm going to start. I'm bringing anger and provocation, not at any of you, but at something totally unrelated to this. Actually, I work part-time while I'm in grad school, and there's some things that have been happening at work, and I'm still feeling activated by them. So those are my feelings, and I'm going to take a breath and release that energy out so I can be totally here with you all.
Amazing.
Audible.
I like the breath there. Yeah, I love that, Brittany.
Yeah.
Amanda, what about you? How are you approaching today?
Oh, how am I approaching? Well, successful, I would say, because I finally decided to sit down and figure out how I'm going to post these podcast episodes. So I did that, and I feel successful. So I'll lead with that, I think.
Absolutely. Dr. Hodge, how are you today? How are you feeling?
I think I was looking at that wheel, and awesome. Again, you guys it's so cool to see your growth and the things that you get out of your program, and continue to use that, right? That take that moment to have that self-awareness. And I think right now I'm going to stay a little playful. So I will try my hardest to stay on track, but
Love that.
We love playful.
Yay.
That's okay.
yeah,
Yes.
like
That's
this is
perfect.
fun for me. So
Yeah.
I will be focused, but a little bit of playful today.
So happy to have you here.
Thank you.
There's so much space for that.
All right, Ash, how about you?
For me, well, I think last time I said creative, and now I'm feeling creative again, and I don't want to be boring. So today, let's go with indecisive. Yeah, I'm feeling indecisive at the moment, and just in general, with just prioritizing what I want to prioritize and knowing what I need to. So I'm indecisive. But
You have a lot of fun
excited.
things
Oh
going
my
on, so that makes
gosh.
sense.
I'm
Yeah.
excited. I'm indecisive. I'm creative. What is going on? There's so many of these feelings. Wow. I need a smaller wheel,
Indecisive.
not a bigger wheel. All right. Well, let's wrap that up. Brittany, thank you for that. I really love that you added that to our show. I think that is super helpful, beneficial to ground us, get us all present in the moment, and get ready to talk about understanding addiction a little bit. So, Dr. Hodge, if you'd like, could you just maybe start us off? Just how do you define addiction?
Oh, that's a fun one. Well, because of course I want to give you the correct answer, right? But also I want to give you my own personal bias and the things that have gone on in my life. Like I told you earlier, I told you I in my master's program was like, oh, I'll never do that. So I'm not going to pay attention. That'll never come up. I'm going to work with anything else but that. And of course, in my own life, family members, friends have all had an issue with addiction. Okay, hold on, it was dramatic. Not all of them, but some of them, right? And it so quickly can change from I'm sitting here with you all, and so quickly it could change, right? I could make 4 or 5 decisions different today that I've seen people do, and they're in a totally different place in their life. I think working with clients who are actively in their addiction is very humbling, right? Because part of my definition is it comes from addiction comes from a place of trying to cope. Okay, probably not. We can get into this. Probably not the best option of coping, but grief, trauma, sadness. Somebody goes out to use something to not feel, not deal. And then you may 5-10 years later, they're still in that same place. So that's kind of my definition of it. But also, it definitely involves a change in the brain and the way the brain functions, right? So it's very important that I think people will hear this idea that, oh, somebody tried something once and they were addicted. That can happen, right? And I know people who can try stuff all the time and not have that addiction come in. And I think there's a lot of research of, your genetics, nature, nurture. We can get into all of that conversation, but at the end of the day, it's that person sitting with you, right? And it's that person who's in the struggle, and just being there and supporting them. I think we'll come back to this later too, but in my world, and when I work with somebody in addiction, the goal is not always sobriety, right? The goal is, what can we do today? What will that look like? And if we get to sobriety, that's great. But
That sounds
right
exhausting. Like, what can you do seriously thinking about that? Like, how can I show up for myself in this moment to moment? Like, I mean, that sounds exhausting.
Yeah. But I think it's also important to remember, right? Like if you, as the clinician, go in with the goal of this person will be sober and then I'm a good clinician, you're going to miss it. You're going to miss it every time, right? If it's, I'm going to work with this person, and if they use less than they did the day before, that's huge, right? And also, if they used way more than they did the day before, it doesn't mean I'm failing, right? As the clinician, it means I'm still there, I'm still supporting, and people are going through it,
I think there's so many times, especially like for me, I am, a gambling addict, and I go to, Gamblers Anonymous and all these things. And for me, harm reduction wasn't something that helped, and it wasn't really an option. So as abstinence was, and it took us going to a conference this year for me to recognize harm reduction has its place, and it can be so, so meaningful for people. So I'm really glad that you point out the importance of recognizing those moments and recognizing those, even if it's an incremental success, it's still something that's meaningful and can really change someone's life. So I really appreciate that, and, what do you think counselors and the public what should they understand about the neurobiological and the psychological mechanisms of addiction?
So I love the brain, all right, and I love that we're all studying it now. Maybe we have been for a while, and there's still a lot of areas that I don't understand. It's the never-ending thing to look into, right? And I think what it comes down for me is I'm not a neurobiologist, so I'm going to misplace the reward receptor locations. I'm sure you'll go over that. But what I can tell you is that addiction changes the way your brain responds to things. It does. Like there's imaging. I mean, there's CT scans that can show how the brain lights up on different substances, how it will light up while someone's gambling. And when you do that consistently enough, you're rewiring your pathways, right? You're rewiring your brain. And so I think there's a shift in the conversation of this is not just a lack of willpower. This is not just I woke up and now I can't. The chemicals and the way my brain have responded have totally changed, right? So I think what's really great about therapy is we're not neurobiologists, right? I don't know all those different areas, right? I have some working knowledge of that, but what I can do with a client is let's stay focused on that habit. Let's stay focused on that positive habit. Like let's stay focused on what are you going to do today that you couldn't do yesterday? What is the next step? What is the next thing? And being that support and being that person who is rewiring their brain with them. That is not an overnight change, right? Now we can talk about there are medications that will help. There are different things that will assist in all of that. But as the therapist, the person not prescribing medications, we get to do the work. We get to see how we're carving out someone's new neural pathway. And this is the good and the not so good, right? Is sometimes in my world, I don't get to see the fruition of that. Sometimes I get to just start at the beginning with somebody. I'm just planting the seed. Like, here's the little things we can try. Sometimes I work with someone who's in recovery. And so I'm seeing that fruition. I'm seeing that. Sorry, I'm going into a gardening metaphor, but now the flower's blooming and now I can see that. But some of that's lifetime work for some of your clients. Mm-hmm. So that's good to hear, right? But it's also can be frustrating if you're not seeing that consistent change, because think about it, rewiring someone's brain, that's not an overnight thing. As a clinician, you can get really lost in, oh, it's not fixed, or I didn't do the thing. No, sometimes it's just those little things that you're adding to with a person that will add up in the long run.
Well, before we move past this topic, so I'm curious what your thoughts are about using like psychedelic or assisted therapy in this area, because the whole point of that is like it's like powdered snow on top of your neural pathways. So now you get to like rewire, right? And so I want to know if someone has an addiction, it seems counterintuitive. So like, what are your thoughts and feelings on that?
My biased thoughts and feelings. All right,
yeah,
I can just do
it.
I love it. Okay, here's my feelings in this work is whatever works, use it. Okay, whatever. And I think we'll talk about it later. There's this idea of, everybody's looking at this from the court system to therapists to neuro people to medication assisted people. Whatever works for you, please do that thing, right? And so the psychedelics, right? I hear what you're saying. How do if I take this medication to not use this other substance, that's kind of weird. Okay, is it legal? Are you able to get through your day? Are you able to hold a job? Are you able to do the things you weren't able to do while you're in your active addiction? Awesome. I'm all for it. Let's do it. And I think that keeps going back to, and maybe Ash, you're picking up on that, is that harm reduction, right? If you can use something, psychedelics, whatever, and it works for you, use it, please, right?
That's extremely powerful. Yeah. Well, let's move a little bit to just kind of clarifying some things. There's often a confusion between substance use dependence and addiction. Can you maybe break down these distinctions, and how do we know when something has crossed the line?
So I'm going to break this down very professionally, and then I'm going to use my fun metaphors, if that's okay.
Amazing.
So substance use, that's just simply using the substance, right? I have a substance right here. It's called caffeine, and I'm going to use this, and don't take it away from me, please. Okay? Thank you. So the dependence refers to a physical adaptation to a substance, so the body can become tolerant and it can experience withdrawal symptoms, and dependence can occur. And then addiction goes on that physical dependence, and it includes compulsive use, loss of control, continued use despite harm. And Ash, what was the last question on there? Like what?
Just how do you know when it's something has crossed that line into addiction?
So I think that's where our DSM really helps, right? Because it breaks down the qualifiers. So, and I had to write this down because I don't, you know, as great as I am, I can't remember what they are all the time. But it's 2 out of the following 11. So under impaired control, it's using more over a longer time than intended. You can't cut down on your use. Time spent on getting, using, and recovering, and then cravings. In the area of social impairment, it's failing responsibilities, interpersonal problems, giving up activities. In the area of risky use, you can put yourself in dangerous situations, and you're using despite the health problems it may be causing. And then the DSM spells out the severity, right? So if you have 2 to 3 of those symptoms, it's mild, 4 to 5, moderate, and 6 or more severe. So thank you, DSM, for giving us that kind of guideline. I think the other thing that really helps is when your client is telling you, hey, this is beyond what I thought it was going to be, right? This is not what I expected. I did not expect to wake up in pain one day and my doctor prescribed me an opiate, and now it's a year later and I can't afford that, or they cut me off. And so I had to switch to heroin. I had to switch because my body became dependent upon it. So it's also when the person is there saying, oh, my life is like drastically changed and I am seeking that help. It's no, I was gonna say it's funny, but it's not funny. But I've had a lot of friends in my life. We'll sit at the bar. Well, I'm not an alcoholic because this, and this. I'm not an alcoholic because I can go to class tomorrow. Okay, right? So it really is that personal perspective too, right? If it's not causing you harm and you can do your substance and go on with your day, does it qualify you? No. Is it also something I would definitely not recommend? Yeah, for sure.
Well, I have a question. Sorry,
Yeah.
Ash. When we were doing our Genius Academy, and so for people listening who are not a part of our asynchronous courses, Genius Academy is like it's an AI generated, like pre-recorded videos of clients for us to work on specific evidence-based skills. So imagine us like talking to a screen and we're being prompted on like how we're supposed to respond to this client. And one of those clients, by all diagnostic criteria with the DSM, has a alcohol use disorder and really refused, even with like collateral sources, like talking to his family, really refused to accept that it was a problem. And so how do you were counselors in training, and I don't know that I've ever really got a good answer on like, we kind of just moved beyond that. We had other clients and kind of moved beyond that. And I was like, wait, but like, what do we do? Like, what do we do here if we've, tried talking about the diagnostic criteria, or if we had, there's like these questionnaires that we could do in session, right? And what if we've done those and that's still not evidence enough? Like, how do we then, our client is obviously not ready. We always talk about like client readiness. How do we help our client get ready then? Or like, how do we help them understand what the situation is?
So we try to control it, and we beg them, we plead, and we also find out somebody's not ready till they're ready, right? So Brittany, I really appreciate what you're saying. It is the hard part of the job. You can clearly see it. You see it clear as day, and all the issues that are coming their way or will come their way. And you say, please, like, look at this. I'm here to help and support you. And they say, not today. And you say, okay, right?
Okay.
And you
Okay.
say, when you're ready, I'm here. Now, unfortunately, in my career, over the time that has happened, I usually do end up seeing someone because now they're court ordered. They have to be there.
Mm-hmm.
Not the
Oh,
route,
wow.
not the route I want for them, but you
Right.
cannot work harder than your client. You cannot.
Mm.
Well, you can try and then you'll burn yourself out. But I appreciate you bringing that up because with this simulation that we did in class, yeah, the character in question was like, nah, not a problem. No, not an issue. All of us are like, well, clearly an issue, right? So get
Very
it
clear.
together, come to therapy. No, and no, you cannot make someone ready if they're not ready. And I know that's hard to hear. I wish I had the magical thing that'll just come to therapy. That'll be it. And no, we have to let people
Mm.
be ready when they're ready.
Yeah.
So
That whole
basically building that rapport so when they are ready, you'll be there and have that kind of already built,
Yeah.
maybe. Yeah.
Yeah.
Okay.
And I think it's also really helpful to build that rapport with the family, right? Because they're sometimes the one they're saying like, oh, help me, please. I don't want them to go to jail. I don't want all these consequences. And yeah, I know you don't, but it's out of our power, right? It is not in our power to make somebody heal. It's not even in our power to make someone heal. All we get to do is show up and be there when they're ready. And so for the family, it's always having those really good resources too. I'm sure you all have heard of AA, but there is for the family, oh my gosh, losing it.
Al-Anon?
Thank you, Al-Anon. What a great resource, right? AA is for the person in their addiction or working on it, but the family needs that support because society is giving them so many different, like, go this direction, do that, do this, pull them along. And until they're ready, there's not much else. You can just be there. Yes, you can. You can be there and support the family, but can't do it for them.
I that brings me to a question then. I know we just talked about like if someone, is not ready, what do we do? What if it's the opposite? Like, what do you do when you have a client who wants more than anything to get through, their addiction and what's happening and they're just not seeing success? Like, what does that communication look like from the counselor's point of view?
I think, of course, everybody is going to bring your own self to that, right? And really that's for me, that's a great time to be a cheerleader and say, keep doing it, keep showing up, and trying also to help somebody understand your brain does not rewire overnight, right? Stuff just doesn't happen overnight. And sometimes, honestly, in addiction, that's really hard to compete with, right? If I have a substance over here, I know I can take, I don't have to feel anything, deal with anything, it's instant. And yet my therapist is over here saying one thing at a time, one moment at a time, take a breath. What? So it's really sticking with it, being that cheerleader. And you're probably going to hear me say this over and over again, but that humility of, right? Like being humble and saying, I could easily, something could come into my life. I can make some decisions differently. So what would I need sitting across from the table or sitting across in a telehealth session? What would I need? And you bring your personality to this, right? You bring who you are. If you're not a natural cheerleader, don't sit there and try, okay? Because they're going to be like, ooh, what are you doing? But if you have research, you're really focused on goals, like whatever you work really well with, keep digging in with that. Because again, you may not see the full fruition of your work, but you're doing work.
So you're saying we should definitely pick a theoretical framework?
Okay. Depends on who's going to hear this. Yes, I think you should find the one that makes the most sense and fit for your personality, right? You can't get away from Carl Rogers. Like he is the ultimate. I wish I could emanate him every single time. I'm not him. I'm not a Carl Rogers. I'm just not that, right? I'm myself. So, I think it's also important to align with your theoretical choices, but don't forget you. Okay, you are the person in the room. You are important. And if you're throwing out DBT and CBT and you don't, you rather throw out MI, go for it. Do that.
Absolutely.
But yes,
I
in your
love
program,
that.
pick one and write about it. And stay focused on that. No, I'm just kidding.
I love that. Dr. Hodge, so with addiction, it's often, we hear people talk about it as a brain disease. How do we know, or how does current neuroscience support that view? And like, what does it mean for treatment?
I think what it means for treatment is the purpose of saying it in that way is to destigmatize, right? So I said earlier, it's not a lot of the terminology that you'll hear out of the addiction world is on a moral standing, right? So my best example of that is I'll work with people and they'll say, "Oh, I'm clean," or "I'm dirty." And as a supervisor, my very first thing is to tell my clinicians, we don't talk like that. We are neither clean nor dirty, whether we're using or not. And I hope you're hearing that that's from a moral standing, right? It's from a different time and place where it was, that's how it was looked at. So either you're actively using, you're not using. There's different ways to say that. And it includes, in our world, it includes the brain and the behavior, right? So it's not just about, okay, take a medication to support my brain. It's about the therapy that I bring to it and how we can rewire, which could be, again, like I said, that CBT, DBT, motivational interviewing, whatever you as a therapist can bring into that. And it also, I think when we talk about the brain and how and addiction and all that, it brings into perspective like intervention, right? If we can start this information younger, we're going to see greater success. Now, I'm about to say stuff that gets people all riled up, right? Is like, would I, under the age of 18, if somebody's already starting a substance, do we wait till they're 18? Yeah, for some of this stuff you do. You have to. That sucks, right? If somebody's actively in their addiction and they're 16, we don't want them to wait to be on a medication or find the support or go to inpatient treatment. So I hope with more of this information coming out, we can start younger, but I know that some people may not like to hear that. Am I answering that question? I feel like I'm going on a weird tangent. Okay.
No, it was good. You're good.
I also think it's important, like I'm going to go back and say, you're the therapist, right? You're not the doctor. You're not the one to say, oh, this medication is better than that medication, because that changes all the time. I don't know how doctors keep up with that. You're the therapist. So one thing I really want to bring up today, which I think is very supportive in the work, is Skinner. Okay, who remembers Skinner? Who remembers operant conditioning? Yes, behavior. And so the rats, that was funny. So
that's how I remember it. I don't know why.
If you look at his work, even with addiction, different things, it's about that reward system. So if you think of your brain and the reward system, and I take a drug and I'm high, that's a reward, right? It's hard to compete with if we're just sitting there breathing and talking about certain things. So I want to go over that just for a second. Don't feel like you're in class or anything, or tune me out if you know this. But
it's so important though, Dr. Hodge, because we're even preparing for the NCE and this type of stuff is on it. So thank you go ahead. Tell us about it.
So, okay, reinforcements, right? So the positive reinforcement, we're adding something good, like getting praise for doing a good job. Those A's that we give you, good job, here's your A. The negative reinforcement is removing something bad. And I think a good example of that is like taking an aspirin to remove the headache, right? But then in this, there's also punishment. So positive punishment we add something bad so that the behavior will decrease. So an example is like getting a speeding ticket, right? Hopefully you get that, you're going to decrease that speeding or that behavior. And then there's the negative punishment is we're removing something good. So hopefully the behavior decreases, like losing your phone privileges or going to jail, right? The thing with addiction, right, is it is an instant positive reinforcement. Your brain, the chemicals in your brain have changed. You feel good. You get this high, this buzz. The negative reinforcement is you're escaping the sadness, you're escaping reality, right? But the thing with addiction and like gambling addiction, right, is that intermittent reinforcement. You never know when you're gonna get the hit. Oh my gosh, that is such a interesting concept if you keep studying this behavior system, that of course I'm gonna hit that button until I get something out of it. And all of this, however you're getting the reward through the addiction, through the gaming, through the gambling, through whatever it may be, you're rewiring your brain every time you do that, right? So I really wanted to talk about that today, because when we talk about what works in addiction, well, it depends on how you got there, right? If you got enough negative reinforcements or enough positive punishments, that's a different way to treat that, the way your brain has been wired, than somebody who's getting, intermittent rewards. So it's really important to think about, and as non-neurobiologists, but as therapists, it's important to get that background information, right? Oh, when you were younger and your parents drank in front of you and you never saw an issue with that. Is that nature or nurture? I don't know. But then you started, right? So now you're drinking, and the only time you got in trouble was that one DUI. So that's not the thing, right? What is the thing that's going to support you? We really got to look at that whole story, that whole way that they ended up in front of you. Does that make
Do you look
sense?
at like, do you also look at, so I feel like you're not saying this word, but I'm curious if it
Sure.
matters, like motivation, like the motivation behind the choice or the motivation behind the behavior, because there is a question on here about DBT, and really it's my question because I am on my high horse about DBT and I want to understand. I know it's like chicken or the egg, like did I have this big feeling and I didn't know how to cope with it, so I like made this choice, or like had I made a choice in the past and now my brain is that way and so now like I continue, like I feel like my brain can't understand, and I appreciate that there's space for all of that to be true, but I would love to hear it from an addiction specialist because I don't feel like I have an opportunity to talk about this or to learn about like why are we not using, to my knowledge, we're not really using DBT that much in this field. It's really like a borderline personality disorder and intervention, and I don't understand.
Well, let's go there. Okay. DBT, so a couple of reasons, right, is, oh, well, yeah, I'll go there. One of the reasons is insurance reimbursement,
Okay,
right?
Hey, that
If
matters.
it
that
does matter,
matters.
right? That's a whole different podcast, I think, but a whole different one. I can tell you in my state, in New Mexico, they're definitely reimbursing at a higher rate for DBT if you're trained. But I can also tell you the training and the certification is very secluded. I mean, very expensive, and you got to keep doing
Okay.
it. And so, mathematically, is it worth the extra reimbursement for the DBT and showing that you can offer that technique versus motivational interviewing, CBT, right? So you're
Okay.
asking a question that is beyond your time, right? Like when you're in the field, and if you have the training and you write your notes and you have the DBT, yeah, you should be reimbursed for that work. You should use it, but also it shouldn't be the motivating factor for what you're using with your clients.
Right.
Did that make sense? I could keep going off about insurance, but maybe not. Like I too,
Yeah.
I believe in DBT. I have a great workbook, but it kind of starts to like narrow in your options. And for me, like I said earlier, whatever works. So if you need
Mm,
DBT and you need CBT and you want MI and you need this, here,
okay.
take whatever you need,
Mhm.
right?
Yeah.
You're like really highlighting such an important part, I think, for us as counselors in training to have knowledge, skill sets like integrative,
Yeah.
and how we should have knowledge and skill sets beyond just like, oh, I really like this theoretical framework. But the truth is not it's not a one size fits all for every client. And we're gonna have to be adaptable and to be able to provide information and treatment in a way that's meaningful to the client. Because ultimately, like that's the goal. Yeah. So thank you for also saying that.
Well, and that's again why I wanted to re-hit the reward system, right? You may not even know that. You may not be the one doing the assessment, so you may not have the full history. And so you really got to, ask specific questions when you meet with a client, not just, oh, you got a DWIs and the court said you got to be here. Okay, here we go. Great. What can we do to get you through that? But really, how is this person's brain, how is the reward affecting them? Um, I'm trying to think of another example where the brain will do this is like the difference between anxiety and depression. Okay, so I often have clients say, well, I'm depressed and I have anxiety and my doctor put me on this one, but I still have this issue, right? And I'm like, well, it sounds like, they started in the wrong category. Of course, I wouldn't say that, I had to talk with your doctor. Medications are interesting, but if you're taking an antidepressant and you're still being depressed, but really the underlying cause of that is your anxiety,
Mhm.
we might have missed that, right? I know that sounds like this big pathway of trying to figure it out, but that's where motivational interviewing really comes in, right? Because it helps you and your client see those areas where they're not oh my gosh, what is that term that we use in my uh
What's
ambivalent, right?
yeah.
Where, oh, I definitely know it's this. Well, okay, but it sounds like this, right? Sounds like you're saying, or maybe we're dealing with that. And that really can help you and your client get to what is the thing that's going to support them the most.
So we have been to a conference and they sort of highlighted CBT as the gold standard in working with people with addictions. And so, yeah, we want to know what are some of the most effective and empirically supported treatments for addiction today.
Um, Hold on, I have a list of that. Well, I'll just tell you off the top of my head. No. Okay, so CBT, yes, because it focuses on identifying changing and maladaptive thoughts and behaviors. Like we talked about, motivational interviewing, right? It resolves that ambivalence. See, I wrote that word down and then couldn't think of it. Resolve that ambivalence. Another evidence-based is medication-assisted treatment. Sometimes they call it MATS, but and that's where a majority of my work has been in medication-assisted treatment. I've really gotten the opportunity to work with doctors and nurses and that whole area that I did not go to school for. They're really helpful of like this medication supports this, but you stay over here and do the therapy and do the CBT or the MI or DBT or whatever may work with that client. And another one that's coming up that is evidence-based is that contingency management plans. So this is where it's providing what I consider reward-based. If you come, I'm trying to give you an example is, so when in some areas they have young adult programs, right? Where if you come in, you do the treatment, we'll get this felony taken off. And the treatment is
Mm,
coming for
okay.
session, it's coming for group. This is not in every location everywhere, but I really think contingency management shows if I and every program's different, but 18 to 26, if I come in as my first offense and I do the work and I could get that felony off my record, again, if we can get people earlier, we're going to see a better results in the long run. So those are really great programs to all incorporate in. What else was I going to say about that? DBT, of course, I agree with you, Brittany. It is really effective. I think the issues, again, there are the training, the reimbursement, and some system limitations, depending on where you work, depending on how what they require, right? But if you find yourself in a place where they're not utilizing that, I feel like a lot of your supervisors or people you're working with will find ways to continue to have you get the trainings or different things that you're wanting to incorporate into your sessions.
I appreciate you sharing that about DBT because I honestly didn't know that. It's an area that I'm interested in, and this is not the topic of this conversation, but looking at an LLC and potentially like being able to take different trainings and leveraging the tax benefit of an LLC in order to do that. But I didn't know. I mean, I've been looking at like with Amanda, we had been looking at some IFS or even EMDR trainings, and they're expensive. Like the truth is that they're like in the thousands, and oftentimes they're interstate. So like you also have to travel there, and those are just things that I don't think I really understood. So.
Yeah. Please let me on that podcast. I have the title is The Business of Mental Health, because
Nice.
I don't want to jump ahead, but I think it's one of the questions that, is you were going to ask me about, like something in the future is at the end of the day for you all in the training that you're going into a business as well, right? So, it's like a really hard to wrap my mind around that still. I have the training, I have the knowledge, I can work with people, but what do you mean everything I just did doesn't get reimbursed? What do you mean insurance? What do you mean, right? Like I'm doing good work here, and I'll prove it to you through my notes, through how I write, through the work, but there's a whole different side. But okay, don't get me started. I will sign me up for that one though. I love to talk about that. But Brittany, and I'll go back to what you said too. I've worked in a medication assisted treatment facility. It was a methadone clinic, and my boss, my supervisor there, when somebody really wanted to get out and get the training in EMDR or that specialized DBT training, they were more than willing to pay for that extra work if you would give a time requirement. Like
it was like indentured servitude, because that's what it sounds like.
A little bit, right? Like I'll pay your $2,000 training if you stay on for 2 years. And so it's not like out of the realm, but I agree with you. It is more, it's more money. It's more things. I personally haven't done the EMDR training, done the DBT training, because it is more money, and I have a whole bunch of tools I got, from my education that I can go to. So really it just does depend on, it just depends on where you're at, if you can or can't do that. And it depends on those clients that are in front of you, right? Do they need that neural pathway reward system of DBT? Or do they just need to know you're going to be there the next day? And when they mess up, when they have a relapse, that you're not going to kick them while they're down. And you're not going to say, really? I gave you all the DBT. Why don't you listen? No, like, that's okay. Let's go. Let's try again, right?
Yeah.
Yeah. Well, even with like you're talking about, sometimes we're not successful, I guess, which is kind of, I think, not a great way to look at it based on what we've talked about, right? But even with these like regulations, there's relapse and there's burnout, and those are challenges in addiction work. And so how should clinicians approach measuring what success is in recovery and maintaining resilience?
So that's a great question. And I'm glad that you're bringing it up because, yeah, it's one of the reasons why. And in my master's program, I said, nope, never, no. I want to get that feel good feeling, right? I want to go in, I want to tell my client, here's all this good stuff, and let's breathe and let's do it. And the next time I see them, they're doing that. And in addiction,
Mm.
every day can change, right? And so for me, it does come down to having really good supervision at the locations you're at and kind of understanding what your supervisor's motivations are, right? If it's more people, more money, ooh, burnout guaranteed, right? If it is you show up, you do the work, you put your effort in, you show in your notes justifying why you're doing the things that you're doing, cool, I'm all for it. I have supervised a lot of people, a lot of clinicians who worked in addiction, and I can tell you they do get burnt out because if success is the almighty dollar, you guys chose the wrong career path. I'll tell you that much.
Mm-hmm.
If success is my clients are getting negative UAs and my clients are not staying in the court system, then I'm the one doing all that work. Ooh, no, 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 no. You're not. I mean, you're supporting them in their recovery and in their work. And so really, if you can start that shift now, that you are not, as a therapist, you're definitely a help, you're definitely a support, but you're not the, end all be all for their work. I think that's where you get the greatest success. And it's okay to say, I showed up, I did what I could, and somebody still struggled. That's okay. At least you showed up again, and you keep showing up.
That's what I was going to say. It sounds like almost, a way to look at success in working with addiction is simply being present, right? Like your client being there is a success. And so it like gives you more opportunity. So thank you for that. How do you navigate supporting clients that maybe there's some inequities surrounding access to care, both institutionally and financially? In what ways are you able to still provide effective and meaningful support with those barriers?
Yeah, I feel that, at any moment that can change too, right? So right now there is a lot of support. Oh my, I feel like I have a dance around this for some reason. I feel like Medicaid and, there are systems that are in place right now that are very supportive of clients, right? Who, thank you, Brittany. I'm like, how do I talk about this? That,
Sometimes we
really,
just got to say it.
Yeah.
we're living in a crazy time is what I'll say,
Yeah.
right?
There we go.
What has worked for many years is now being looked at as the thing that's not working. So it is a little, I got to be honest, even for me, it's a little scary, right? Because we have always been able to find, if you don't make a certain amount of money, there's a certain thing we can do, sliding scale fee. And in my state, we've had a lot of success. I remember there were years where single men couldn't get a lot of support because they didn't qualify for Medicaid, they didn't quite, for services, and then that changed, and now a lot of my young guys who come in through the court system, which you got to pay the court, you got to pay, you got to pay for your therapy, but they've been able to get on Medicaid. They've been able to do these things. And, to be honest, if things change, that's going to be a little wild. And I hope it doesn't. But so far in my career, we've always been able to find a way to support and help. And there are a lot of people, there are a lot of groups out there that are also supporting. I cannot think. Mothers Against Matt, right? Mothers Against Drunk Driving is really good.
Yeah.
Like,
Mm-hmm.
there's really good support people out there who have been through something, who have, like, if you can connect and in your network say, this is who I'm with and this is what they're struggling with, people are more than willing to help and support, especially in the addiction world.
So then you have said to us that this isn't a place you thought you'd ever be, but here you are, and you're obviously loving and thriving in it. So, what advice do you have for any counselors in training, people like us, who are considering working with addictions, what sort of like skill set or personal strengths even that you think are required to be an effective counselor?
I think one that I'm not even good at, but I see in a lot of people, which is great, is having that ability to stay calm, stay in the moment, and not let whatever somebody is going through affect you. I've worked with really great people who can sit in a room with somebody who's in the middle of a substance abuse psychosis, substance-induced psychosis, and they're going off, and I'm like, oh my gosh, how are you not, getting energized and their energy and your energy and, just remaining calm. So one big thing, of course, is your own work, that self-awareness. And a secondary to that is noticing in your own life where addiction has affected you. So I'll give you a really short story short story of a long story is my own dad was in that time where opiates, the doctors were overprescribing. So he was in that category of people who got overprescribed, right? So it affected my life in a totally different way. And when I would meet a dad who was there for opiate addiction, I was like, oh, my own stuff coming up. And having a really good supportive supervisor, really supportive person who you could say that to without the judgment, without, your stuff has to stay at the door. It comes up, right? So having that really good supervisor and what you all are doing, right? Having your cohort, right? Oh man, I had a rough day. I'm having a hard time disconnecting from this client to real world, to life. What are you guys doing, right? Having that community and space for yourself is really important. I hope we're reiterating that a lot. Taking care of you, taking care of your stuff, that self-awareness, because it comes up. No matter how much work you do, it comes up. So continuing that, never ending, whatever that may look like. For me, in my master's program, we did all that journaling that you guys, I know you love. Guess what? I still do that. I still journal. I still need a space. So we don't do that just to torture you, I promise. We do that so you can kind of stop and see those biases, see those things that are coming up for you. And, it really is helpful to figure out for yourself the things that you need, because it will come up. It'll shock you in the middle of a session. And you're like, oh, I'm getting triggered. Weird.
So then what about self-care?
Oh, yeah. Always never ending self-care, whatever that may look like. And again, I'm going to go back to what I said earlier. Whatever works for you, if it works, right? Do it. Please don't not do it. Just self-care. If that's hiking, if that's bubble bath, if it is what it is, do that.
Well, are there any other questions, Amanda or Brittany, that y'all have as far as anything we've talked about, or even just the advice for aspiring counselors? I feel like we've hit quite a bit of it, but I don't want to wrap it up too soon. And we have one last question for you, Dr. Hodge.
Okay.
Good. All right. It's just so insightful, and I feel like this conversation has become a lot more organic than some of ours are. And we just have been able to build off of what you're talking about. So it's fantastic. And
thank you.
I feel like I've learned a lot just from this recording. So last question that we have for you, Dr. Hodge, is what gives you hope in this field now? So including prevention efforts related to gambling addiction and legislative type things going on. Are there emergency trends, tools, or ideologies that feel especially promising?
Oh, that is a really good question. I think what gives me hope more often than anything else is just the client in front of me, right? For right now, where I'm at in my career is I'm noticing this pattern of grief, right? This grief, not just of the loss of a person, but maybe it came out of COVID, right? The grief that we all experience, shared grief, a loss of job opportunities lost, right? And some people, when they experience grief, to not deal with it, they've chosen to pick up something to not deal with it. That actually makes perfect sense, right? I mean, who in here, who listening, hasn't done that? maybe it's not cocaine or methamphetamine, but it's this, right?
Or like
Um,
running excessively, like I mean, yeah,
Mhm.
even like
Mhm.
healthy coping things can also be like an avoidant, yeah, avoidant
totally,
mechanism.
right? Totally. And so just like we talked about, it's sitting with that one person, right, for that 1 hour and trying to map out that reward system for them, right? And just like you said, Brittany, I have clients who are addicted to the gym. Am I allowed to say that's good or bad? Nope. But I'm like, hello, it's maladaptive. You're avoiding your family, but okay, let's go to the gym again. So, really, another area to think of is like the good and bad and all of that, right? It's really easy to look at someone on the street and say, "Oh, bad, you know, you did everything wrong." Oh, but you're going to the gym 7 days a week for 4 hours a day. That's great. But no, like the coping is
Mhm.
is the thing, right? And so I do think the phone is going to be another big thing that we see in addiction work for kids. You know, I work with a lot of 11-year-olds and social media and the phone and like this,
Mhm.
it's opening a whole bunch of new conversations I haven't had to have in the past. And so that's something for me in my career. I'm like shifting, right? Like cocaine and that fast hit and that fast reward. Your phone's doing the exact same thing to you, but that's legal. Like it's kind of
Mm.
hard to wrap your mind around if you think about that. Um,
Yeah.
but really it's how do we come back here? How do we stay grounded? What can I give you as my client? How can I support you in that? And that's for anybody, right? You got even you guys, you're in school. How do you like step away, stay grounded? It's that self-awareness, that self-care, and it can look different. So um the other thing that I hold on to for hope is just this big toolbox, right? Just dig in there, grab something that can be as simple as coloring, that can be as advanced as EMDR. But like I said, whatever works, works. And if it's working for your client, keep going, right? And
Yeah.
I do know it would be easier to say the things that are scary that are coming up with legislature and different things, but really it's you at the end of the day. And it's okay to, it's okay to say, oof, I don't, things are weird, and your clients are going to say, hey, man, things are weird. And yes, so how are we going to get through the next day? Right. So I hope I answered that question. The other thing I'll say too is that gives me a lot of hope is are you guys, right? Like you're in this, well, okay, you're in class, you're like, hearing all these stories and you're like, yes, I'm going to get out there and help and support and be successful. And then I talked to Dr. Hodge and she was like, ooh, success means being humble. What do I get it. I've been there. I'm like, the only example of a therapist I have is, what about Bob? So, good one. So when you get out, learning about yourself, taking care of yourself, when you're with that client, what does that feel like? Noticing that but your generation of already like connecting with one another and supporting each other, like that brings me a lot of hope, right? That brings me a lot of hope for our field. And I said this in a different podcast, even if you get into it and you're doing the one-on-one stuff and you say, "Ooh, this is not what I thought." Stay in the field, research, give back, answer questions from PhD students because they're always looking for somebody to volunteer for that. Giving back into the mental health field is the thing. Don't just run away. I'm not saying you will. I'm just saying like stay in it. And in any way and opportunity that you can is giving back. This podcast, you guys, you're already giving people a different sense of hope because then they have a way to like, well, where do I find this? Who does this really well? So give yourselves a lot of credit, right? For thinking of this, for doing it, for supporting your peers, yourself. I'm just really, really impressed. Like I said earlier, this is awesome that you all are doing this and setting up for future generations, right? To continue to stay in the field, work in the field, and give back to that mental health. So thank you guys.
Thank you.
Thank you. Yeah. Thank you, Dr. Hodge. And Thank you to everyone for joining us for this important conversation on addiction with Dr. Rebekah Hodge. As future counselors, peers, and advocates, we have the power to meet people with compassion and walk them towards healing. And we hope that you gained some insights from this episode. If this episode did resonate with you, we ask that you share it with a friend or a colleague, and be sure to follow Counseling Stars on social media for more student-led conversations that matter. Thank you.